Welcome everyone to this month's discussion on an interesting article published in the current issue of Neurogastroenterology and Motility journal. My name is Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It is my great pleasure to welcome Dr. Frank Zerbib. Dr. Zerbib is a professor of gastroenterology and head of the GI department at Bordeaux University Hospital in France and a member of the ESNM, or the European Society of Neurogastroenterology and Motility Steering Committee. He's also the lead author of this European Society of Neurogastroenterology and Motility, as well as the American Society of Neurogastroenterology and Motility consensus paper, which was developed together on diagnosis and management of refractory gastro-esophageal reflux disease. This was published in the current issue of Neurogastroenterology and Motility journal, and Dr. Zerbib is here to discuss the findings from this consensus paper. Welcome, Dr. Zerbib, and thank you for joining us for this chat today.
You're welcome.
I would like to begin with some background on the paper. Can you give us an overview of the importance of refractory gastroesophageal disease in clinical practice?
Well, more than gastroesophageal reflux disease in general, I would like to emphasize on the fact that we are dealing with refractory GERD. We start from the point that it is well known that approximately 30 to 40% of patients with reflux symptoms on PPI do not have an adequate symptom control. So this is an important clinical issue and a challenging situation for many gastroenterologists because it is the reason why many investigations are performed and sometimes many invasive treatment are proposed to these patients. So the problem with this refractory symptoms on PPI is that you may have either an inadequate or an overuse of PPI therapy in many patients, and you may also select the wrong patient to go for anti-reflux procedure. So it is the starting point of our work.
Got it. So you clearly indicated that it's an important problem facing the clinic. But then why is it essential to develop a consensus paper on this topic? Are the practices that vary that you need a consensus paper to guide treatment for this?
Yes, it was considered to be an important issue by both society, the European and the American Motility Society. You know, we had in the past years two important consensus. The Rome 4 consensus, who helped to better define the esophageal functional disorders. And we have now reached a consensus on what is functional heartburn, reflux hypersensitivity, etc., etc. More recently, there was another consensus, the Lyon consensus, which aim was more to define what reflux, abnormal reflux is based on endoscopy, pH monitoring, impedance monitoring, etc. But in fact, there was an unmet need regarding the definitions of refractory GERD. What is in fact refractory GERD? And in the literature, there are many different definitions of refractory reflux disease. And second, there was also a need for a more practical management of these patients based on these definitions of disease and reflux. So finally, it was important to define the good word of refractory GERD for future studies. I mean, if you are dealing with a paper on refractory GERD, you must be sure that you are dealing with the good patients with the appropriate definition of refractory GERD or refractory symptoms.
Thanks. That makes a lot of sense. And again, as you pointed out, this was an unmet need, and it was important to develop this. But it looks like, based on the paper, it's fairly complex methodology. Can you describe the methodology you employed to develop this consensus paper, and also the authors and the societies that participated in developing the statement?
Well, I have to confess that it was not such a difficult methodology, but it was difficult to reach a consensus on many points. So we were 10 experts from the both societies, European Society of Neurogastroenterology and Motility and American Society of Neurogastroenterology as well. And we were divided in subgroups, groups working on definitions and epidemiology, a group working on pathophysiology, a group on diagnosis, and a group on management. And each group worked independently and proposed different statements in their field. And each individual statement was debated by the group and finally approved by all the experts. So it was not a difficult methodology, but it was sometimes difficult to make to reach a consensus on certain points. For example, for the definition of refractory GERD, there were a lot of discussions on this point.
Well, that dives straight into my next question because it looks like you had difficulty coming to the conclusion. So what were the principal conclusions from this exercise?
Yes, as I said before, it was important to reach an agreement on the definition and the appropriate wording. So, for example, we define refractory reflux symptoms, which means that it is the case of a patient with ongoing symptoms on PPI. We don't know if the symptoms are related to reflux. We don't know if the patient has reflux. Second, we define refractory GERD symptoms. It is the example of a patient who has a previously proven gastro-esophageal reflux disease, either by the presence of esophagitis or the presence of positive pH monitoring, for example. So these patients has reflux disease, GERD, and ongoing symptoms, but we don't know if these symptoms are clearly related to ongoing reflux despite therapy. Because ongoing reflux despite therapy, we consider it is the actual definition of refractory GERD. So refractory gastroesophageal reflux disease is a patient with objective evidence of ongoing reflux despite adequate therapy. So it was a very important point, and we hope that in future studies, these definitions will be used. Second, one very important point, which is in line with the previous one, is that there is a need to an objective evaluation of reflux disease in a patient with ongoing symptoms. And then we come back to the previous definitions of the Lyon consensus. For example, if you should have a GERD evidence on endoscopy, GERD evidence on pH monitoring, if pH monitoring or pH impedance monitoring should be performed on or off PPI therapy, etc. But the main point is that whatever the technique you use, you must deal with a patient with objective evidence of GERD. Also, one of the important conclusion, and that we also consider alternative diagnosis, especially we pay some attention to rumination, which is very frequent and very frequently misdiagnosed as ongoing or refractory GERD. So we give some clues to the clinician when and how rumination should be considered in these patients. Finally, we also give some guidelines regarding the treatment and what is really effective when you consider lifestyle interventions. For example, if you want to optimize PPI therapy, what type of adjunctive medical therapy can be used, H2 array, baclofen, topical or protective mucosal agents and alginates. And of course, we also give some very useful information regarding anti-reflux surgery and other invasive management techniques such as magnetic sphincter augmentation, for example. So we try to cover from the definition to the management of refractory GERD.
Great. So I know for the podcast, people can't look at the screen, but if they have a chance to look at the video, they can see the algorithm that you've come up with. But if you were to try to summarize these findings in terms of key take-home points, could you provide some key points that people can take home and bring them to the practice?
I think that as I said previously, one of the key points is that you need an objective evaluation of GERD in a patient with refractory symptom. You don't need this objective management if you have an empirical therapy and the patient is doing well on therapy. There's no need for that. But if you have a patient not doing well, you should go for an objective evaluation, and you have to work on endoscopy, pH monitoring, etc. As all is said in the previous consensus I described before. It is in my opinion, one of the most important issue of this paper.
Great. So in the broader sense, do you think this will have an impact on clinical practice, or what do you think would be a follow-up from this consensus paper that will help you assess that?
Hopefully. I mean, we all know that when you are writing guidelines or consensus paper, they are not 100% followed by clinicians and by the target readers, I mean. But we hope that our statements, which we try to make as clear as possible, will improve the overall management of this difficult patient. And especially, we hope that we will improve the use of PPIs and limit the overuse of PPIs or the misuse of PPIs, which is important. And even more important, we hope that we help the clinicians to better select the good candidates for invasive management of GERD and avoid sometimes surgery which is not always indicated and appropriated in many of these patients. So we give some clues for that, and we hope that we made it clear enough for clinicians to improve their daily management of this very frequent clinical situation.
Great, and since I have you here, I see that you also published another study in the current issue of Neurogastroenterology and Motility on the added value of symptom analyses during rapid drink challenge in high-resolution esophageal manometry. And I thought if you have a few minutes, if you could elaborate on this study and tell us if it does have any implications for either the assessment or management of refractory GERD.
Yes, thank you for giving the opportunity to talk about this paper. It is an original article we have published with Professor Serra from Barcelona. I spent 3 months there as a visiting professor in early 2020. And we analyzed the data that they have in their database of 1,300 patients that had high-resolution manometry in the lab. And it was very interesting because they perform a rapid drink challenge, which consists in drinking 200 millimeters of water very quickly with a straw. As you know, it is a provocative maneuver that may help to increase the sensitivity of manometry and can show obstructive patterns or hyperpressive patterns after this load of water in the esophageal lumen. And the originality of this study is that all patients were asked about their usual symptoms during the challenge. So we could show in this study that approximately 30% of these patients could reproduce their usual symptoms during the rapid drink challenge, and approximately 50% of them had hyperpressive patterns, and 50% obstructive patterns. So it is something that not only may increase the sensitivity of the high-resolution manometry, but also the specificity or the relevance of the abnormality observed during this challenge. Regarding the specific issue of refractory GERD, it's not very interesting, in fact, because it may be useful in some patients with unexplained regurgitation. But in fact, if you look at the subgroup of patients with normal manometry or those abnormality, minor motility disorder that are often associated with reflux, such as ineffective esophageal motility or absent contractility, we could reproduce usual symptoms very rarely in this patient, and especially regurgitation was observed in less than 5% of the patients. So regarding the specific subgroup of patients with refractory symptoms, it's not very interesting. It's more interesting in patients with dysphagia, in fact.
Great. Thanks so much for discussing these two articles. Any other parting thoughts before we sign off?
No, I think I'm okay. If you have any other questions, I'm fine.
No, great. Thanks again for joining us for this discussion about these papers. I'd also like to thank our listeners for tuning in to this month's session of this discussion of papers from Neurogastroenterology and Motility, and stay tuned for another exciting article coming up next month.
Thank you.
Thank you.